What we're going to do is basically go through a program of what we do here for one of our courses, literally going from the planning phase, the components that we utilize to go through the teaching program, and then eventually end up with the actual patient clinical procedures. What you're going to look at is the components. Starts out with the model taken from the impression of the patient, and this is sent out along with a plan, a computer two-dimensional plan on Implant to materialize that makes us a stereolithic model and a set of stents depending on the drill sizes, the twist drill sizes, going from 2 millimeters all the way up to 4.5 depending on the size that's treatment plan for that implant. On this side over here, you're looking at the restorative components. We actually will be utilizing restorative components that are, in this case, zirconium. This is a 4.5 millimeter diameter at the base for a Xi 4.5 millimeter diameter implant, angulated, 15-degree angulation. And next to it is a zircon-made zirconium coping with a retentive component on the occlusal aspect of it. Once the implant is put in, we will put in the abutment, which will actually stay with the patient, and we'll use the zirconium coping and retentive component to take an impression at the time of surgery. We also can utilize an acrylic coping that fits directly onto the abutment, and a standard polycarbonate crown to pick up the coping and make a temporary restoration that same day. For today's presentation, we're going to be utilizing the Xive implant system, Dentsply Freedent Xive implant, and taking you through the kit and through the components and the series of drills. We're going to begin with a 2 millimeter drill. That's usually our standard. Some implant systems start out with 1.5 or 1.8. We start with a 2 millimeter, followed with a round preparation drill just for the crestal component, and then introduce the 3 millimeter drill, the 3.4, 3.8, 4.5, and 5.5 depending on the system. Today we're going to go through our series and end up with the 4.5. With the Xive implant system, there's also a crest twist drill for type 1 and type 2 bone that would have to be utilized along with a tap in more dense bone, and we'll show those components as well. The whole idea of any teaching program is to not only go through the didactic explanation of techniques and procedures or show slides, but also to give the participants an opportunity to actually utilize a hands-on approach, even if it is on a stereolithic model. The great thing about getting such a stereolithic model is that you can actually do the surgical procedure ahead of time and experience it in all its components, so that when you get to the actual clinical procedures, all the components are familiar. The angles that you would be actually sitting next to the patient should be utilized in the same way when you're doing it on the lab bench. So in comparison, I'd like just to show you and compare the stereolithic model to an actual impression taken from the patient. It's actually quite remarkable that from a digital image, the CAT scan image, you can actually create a three-dimensional stereolithic model that's so comparable to a permelastic impression of the patient. In fact, the stents that are fabricated thusly fit just as well on the stereolithic model. There's no rock at all involved in this, and in fact they are transferable to the standard model as you see here in exactly the same way, and again with no rock involved at all, and a very stable type of foundation that you see. Extracting a tooth and placing an implant in the area of number 9. This tooth in number 9 was erupted, probably around 8 to 9 millimeters in the end, and you'll see the x-rays of that as well. But we're going to place an implant here, and in doing so, we need to not only get the guidance from the stent that will guide us relative to angulation of the site, but we also need to know the vertical component that's involved. Okay, this component, so important to know that the titanium tube that's included in the materialized stent is 5 millimeters in length. When you start to put the dimensions together on the model, we need to know if you want to place a 13 millimeter implant, you have to factor in the 5 millimeter of the tube. Probably it's about a millimeter above the gingival margin on the buccal, and you want to place the implant either 2 or 3 millimeters below, plus the 13 millimeters of the implant. So these numbers and this kind of formulation is very important to know ahead of time. So in this particular case, we're going to do 13 millimeters for the implant, 3 millimeter for the transgingival component, and 5 millimeters for the tube. Basically comes out to about 21 millimeters. So in essence, when we're looking at the drill bit over here, we're looking at 13 millimeters being right here. We add another couple of millimeters for the transgingival component, maybe up to 16 millimeters. And so we really have to go all the way to the hub at minimum in order to prepare our site. And we can, of course, deepen it further without the stent in place. So just to get started, we have to make sure that the stent fits well. And you can see that it does in this case. We have to make sure that the stent fits properly. For this exercise, we're actually going to utilize an 11 millimeter implant. So we're going to do 11 plus the 5 millimeters for the titanium tube, that's 16 millimeters. And then we can play around between 2 to 4 millimeters in terms of transgingival. Okay, for this exercise, we're going to use an 11 millimeter implant as a teaching tool. And so we go with the 11 millimeters, we add the 5 millimeter distance of the titanium tube or guide tube that you see here. That would make for 16 millimeters. And then you can decide whether you need to go 2 to 4 millimeters below the gingival margin, depending on the relationship of the adjacent dentition. In this case, we're going to try to go about 3 millimeters below the gingival margin, and we'll get a good purchase point. And literally take it, in this case, almost to the hub. Just like in the surgical component, we can even try in some of the try-in abutments at this time. And you can go in with either an angulated abutment and try to see how that would line up, in essence, how an angulated abutment may line up relative to the adjacent teeth, or whether you would in fact need to utilize a straight abutment. So this is just as an example, just for this exercise, looking at utilizing a 15-degree angulated abutment. We're using the 3.8 guide and looking at it a little bit from the side. It's not really a true guide because it's not into the depth of the preparation, but we'll see that as we move a little bit further along. We can then move on to a wider diameter stent. you can see here. And in the same way, you can just go in and without really having to think too much about it, take you down to the hub in this particular case. Because this is an acrylic model, we want to actually drill a little bit looser in the sense that we want to have a little bit wider osteotomy in order to fit our analog in there nice and easily. So that's something that we need to keep in mind in making this plan. For precise precision, once you get to this level, we can literally go and place it without the guide at this particular stage. So since the final drill in this case is a 4.5 anterior, you can see that there is 2 bands for anterior xive placement. So we're going to go to 11 millimeters plus 3 for the transgingival. We want to be around 14 millimeters below the gum line. We're going to use the adjacent teeth as a guide. So in this case,
he's going to go ahead and extract the left central incisor, problem a fracture, and we went ahead and extruded this tooth, and once the extrusion was finished, you can see that we brought down the bone prior to this visit, and now Henry's going to go ahead and do an immediate extraction with immediate implant placement based upon the stereolythic guide and the pre-diagnostic CAT scan images that allowed us to plan both the surgery and the restorative phase from inception.
Maurice, what we're doing right now is just we extracted the tooth and we're cleaning out and curating out the defect.
I'm trying to scroll myself. Okay. This patient started, that you're seeing on the left screen, this is what he came in with. Blown out case, much decay. Henry kept a few teeth for transitional appliance, just to give you an idea of how we got to this phase. There was some soft tissue issues on the temporary, so we planned on augmenting the right side for the pondic space. This is what the patient looked like after extraction and cleanup, maintaining a few teeth for an existing bridge. While Henry goes ahead and cleans out this extraction site, I don't think it's that exciting. I'll take you through this very case because this is the patient you're looking at today. Very large defect on the right side. You have remaining teeth on the left side. Implants are going to be placed, but obviously we have a defect here. What we went ahead and did is placed implants in the areas to segregate implant placement, one in the right central, one in the right cuspid region, leaving the lateral alone. And we were going to plan on hard and soft tissue augmentation of the pontic area to bring the bone close to the contact point. We went ahead in this case and we used allograftic bone, a little bit of excitement in this case because we can't always get autogenous bone from our patients or they won't let us do a donor site. In this case we utilized J-block from Tutagen. We hydrated this for 2 10-minute saline baths and we went ahead and decorticated it. And we shaped it in this case like the scallop form of the underlying bone that we'd like to achieve in order to regain soft tissue scallop for our final restoration. And what Henry's doing here is he's going ahead, extracted the tooth and cleaned it out, and he's going to go ahead and place the implant in the area of this tooth that eventually failed. We sutured over the top of the bone. It was screwed into place and maintained, and you can see the shape of this bone on the left side. What Henry's doing on the right screen here is simply going ahead and following the surgical guide. It's going to be 15-degree angulation to engage the palatal bone, stay away from the labial plate.
I'm going to do the next one.
And this is what this case looked like when we had replaced the implants, utilizing J-block to shape the soft tissue in the left pontic area. So you can see how we actually have gone from this situation with a pretty significant defect. Our goal was to come down to this green line, and utilizing combination of bone and soft tissue grafting and placement of the ankylosing implants, you can see that we've been able to recreate the right lateral region and the papillas on either side. This is what it looked like after temporization. You can see the soft tissue healing, utilizing a autogenous mineralized J-block in the area of the right lateral, which is this tooth that's just out of your screen. We thought it would be a bit interesting to show you how we then, early on, started transferring over to zircon implants. So we went at zircon abutments, in this case, for color match and to enable us to get the best aesthetics. This is something that we're going to hopefully be able to utilize today, utilizing Zyve to replace this tooth, utilizing the same concept, but this time placing the abutment at the time of surgery based on this kind of planning and guidance, and going ahead and securing it into place and utilizing coping over the top. Transferring that to the laboratory and never having to take the abutment off of the implant from the day of surgery. And I know we heard yesterday how important that may be in terms of management of the microgap. Not having to put on and off the components doesn't allow for tearing of the juncture epithelium and maintain soft tissue height. You see on this screen, once the soft tissue started to heal, you can see how the ponic, in this case where the J-block was, this is now at about 8 months. This is ankylose, J-block supported papilla, and then another ankylose implant, and then right next to this tooth is the tooth you're looking at right now on the right screen. Just trying to give you an idea of where this patient came from and where he is now. This tooth failed after we kept it. After about a year, the patient came in with a fracture, and we went ahead and had to replace it. This may give you some understanding of sometimes maybe the best option in this case would have been to just go ahead and remove this tooth or bury the root to maintain pontic rather than to keep a questionable natural tooth. And that's something certainly that can be discussed after the lecture.
Yeah, I'll do it.
David, nice job. David, Henry, great job there. Livio, Lori, Charlene, and Christian, fantastic job. You did great.
Post-op, you can see that the tissue is healed real well. And we have not only a zone of keratinized tissue in this area, but also the volume is very comparable to the right central incisor in this area. If we look at it from pre-operatively, which was pretty much about 1 millimeter from the difference from the adjacent central incisor, we've been able to maintain that same difference. So we've been able to preserve the original level. We didn't actually augment it any or bring it up more coronally, but certainly we've augmented it and certainly regained the health of this soft tissue along that line. And all of this is done with one surgical intervention in this endeavor. How are we feeling? How does that tooth feel for you?
I'm feeling a lot better, Dr. Henry. It's much improvement, and I can hardly tell the difference between what you've done and my real teeth that I used to have, except they don't hurt anymore.
Well, that's a big part of it.
Yes.
Excellent. All right, and being able to clean it and floss around it and everything, all right?
Yes, there's no problem and no discomfort whatsoever.
Okay, how about immediately after the procedure, the surgical procedure? How was your first few days?
I was surprised at it, that I didn't hurt more than what I did. The healing process is very quick, so I was happy about that. I was able to go right back to work, and there was very little downtime, which really surprised me from what it felt like you were doing to me. But the healing time was quick.
All right, great.
It was quick.
Excellent. Thanks.